you know, here we are now 5 years into our EMR, and sure, we don't have a lot of paperwork. Our inboxes aren't really full, but we have, in the paper world, but we have desktops that have consults, that have office visits that need to be done, that have referrals, that have phone notes, etc. So we began to look at how we can work as a team to make the whole process better for everybody. So we needed to look at how we could optimize the roles within our team, how we could leverage the providers and that desktop work, how we could have a decrease in time to home for our providers and for our staff. We could increase the accuracy of our metrics, our reportable data, and how we captured them. So we needed to look at roles and responsibilities. So we looked at our clinical support, and we looked at the consult, and we looked at our health information management or our medical records department to see if there was information that clinical support with the right training could get from consult notes and feed that information into the flow sheet to collect reportable data. So could they generate referral orders? Could we set up specialist tests for follow-up appointments? And then also to make sure that there was a follow-through in completing the process. Then we looked at what our HIM department could do as far as was there some data that they could get that from scanned documents that came in that they could put into the medical record for us? Could they preload some of the outside labs, and could they put in some of the diabetic eye exam results? So we use Centricity, and we're very fortunate. We have a great IT department, and we have some great developers in our department. And we began to look at was there a form that we could create for our clinical support staff to use, so if they were reviewing some of the consults that were on the provider's desktop, could they pull some of that information out of that consult and preload it in so that that information was there when the provider then went in to see the patient. So this was a clinical support data entry that we came up with, and you can see that there's spots for pap smears, colonoscopies. There's also a cardiology tab to put in stress test results or ejection fractions, echo results, etc. And then we created a HIM data entry form being sensitive to what their clinical understanding was and making sure that, that they felt comfortable with what they were entering. We have a steering committee with a group of doctors and IT and some of our developers and clinical nursing staff that we pulled this whole thing together with and piloted this so that we could make sure that it was going to be beneficial to everybody. So we did an initial pilot, and we did it with a couple of our providers, Dr. Conley, who's a family practice doc who sees anywhere from 35 to 40 patients a day, and then Beth Remelong, who is one of our providers in another office. So we looked at consult reports. We looked at what was required in those consult reports, and I won't go through everything here. You can see the data. But you can see that for the average time in minutes was about 256 minutes or 4 minutes a document to kind of pull some of that information out. And then these were the documents that we looked at in our pilot phase, which was from March to May. And again, the biggest reason that this was successful and that we were able to pilot this was because we had some docs that really championed this and worked with us to develop this whole protocol. And Jill.
Thank you, Jackie. With the groundwork that Jackie and the colleagues, her colleagues in health information management and others did, we started to use our Microsystems approach in the practice in which I work to see if we could flesh this out even further. We recognized that we were, we were, again, trying to get the provider home on time, trying to increase the face time the provider had in the visit, and decrease the amount of time the provider had to use doing things that other staff members could take on safely and effectively. Safety is a key word here. As a registered nurse, I've been a nurse for many years, but signing consults has never been a part of sort of my workflow. So I can recall I remember hearing Jackie propose this a while, and we were like, oh, I was like, that's so scary. It's really frightening to me. So I had the opportunity, and I guess the need to work very closely with the provider with whom I practiced to make sure that I was signing off on these consults, updating the med list, updating the problem list, doing those things that needed to be done in a way that ensured that the patients were cared for very safely and the people who needed the information had the information. So the provider with whom I worked, we did our own set of audits around this. For a little while, for a week's time, I took every single consult that came into her desktop. I signed it off, and then at the end of the day, we would sort of have a huddle, and we would make sure that, again, I'd hit the high points. I had conveyed to her in the chart the information she needed, and if there was anything immediately actionable, that she would have that information quickly. So I'm happy to say I scored 100%, all right, which was very reassuring to the both of us that this could be done. And so I'll advance this. It was really quite interesting because I found not only was this helpful to the provider with whom I worked, because it again freed up time for her to do other things, but it was also very interesting to me as a nurse. It sort of re-energized my work because, I had a great time reading those consult notes. I had a terrific time reading those plans of care, and it raised a lot of sort of clinical questions for me that I think made me a better nurse. So, again, this is one I sent. I just didn't know if this person should use naproxen because they had IBS. And so I sent that question on to the provider and got a reasonable answer. So as we continued to do this, we got really excited about how efficient we could become. And we started to think about other things that we could do, again, to leverage the physician's time and to leverage the talent in her team. And so then we started to look very hard at what we were doing, what I was doing all day. This is my activity. And you can see in a period, that's actually a 5-day work week because that includes 2 half-days that she works. I signed off 94 consult notes. Now, she says she can do all those in 30 seconds. I am not convinced of that, all right? But all right, it's her thing. But, you do the math on that, and, you could see 10 more 15-minute visits. You could play 18 holes of golf. There's a lot of ways that the providers could use that time that we saved here. So then, I entitled this Paperless Not, all right? Because as I said, as we started to push the envelope in what we could achieve with the electronic health record and having the entire team sort of own the health record, we also started to think about the paper that still came into our practice. And we started to look at what this particular provider saw. And this whole movement toward everybody working at their highest skill level started to translate again into literally every single thing that came into our practice. Similar process. This is all those things that I know you're familiar with. The DMV forms, the orders for the O2 company, disability forms, requests for information from specialty practices. And we started looking at, again, who in the practice can do this. And what we found was that the vast majority of this could be done by the staff with the provider signing off on some of those things that the provider needed to check. And we developed, in fact, an entire guide for managing each piece of paper that came into our practice. Again, I apologize, this isn't really readable. But what we realized is we went from a point where the provider essentially took care of every single piece of paper that came into a practice to a point where the provider only had to manage, sorry, my numbers didn't show up here, guys. had to only manage about half of the documents that came in. Again, a real savings for the time for the providers. So we talked about evolution. Like I said, Jackie and some of her colleagues in family practice really launched this, were really the visionaries around this. And when it came up to internal medicine, after we got over our initial anxiety about it, we began to work the process a little more intensely. We got to a point where not only were we updating med lists, generating the referrals, setting up specialty tests, and completing and process orders to close that referral loop, but we also, with the protocol that we developed, the nursing staff started to sign off on ER reports, H&Ps and hospital discharge summaries, other reports, and to a greater or lesser degree, sending out normal lab notifications to patients. This is, it hasn't happened overnight. I really appreciate some of Dr. Patch's comments about this, because if you think about a practice, different providers are going to have different levels of comfort around this. Different clinical staff are going to have different amounts of experience and comfort around this. It takes a lot of communication, a lot of ability to be honest about one's concerns. But we've been successful in this because we've taken the time to develop some formal policies around it, frankly. And we've taken some time to do some staff training. One of the real challenges we faced is spreading back best practices. We'll literally have a physician working in an office next to another physician, and the way that they manage their desktop and work with their staff will be night and day. And so I don't think we've mastered that yet in spreading some of these gains. But I think we have been relatively successful in at least getting the ball rolling and getting other teams with whom we practice interested in these approaches, at least. We've also had some real unexpected gains from this. The sense of teamwork has just really, it's been quite phenomenal. Instead of all of us running around in our own little world, we are communicating more about the patients. Everyone feels really engaged and has a sense of ownership. It's not just the doctor's patient, it's everyone's patient, and I think that's really been huge. It's really improved our ability to center our care around our patients. And again, I think it's motivated a lot of our clinical support folks, and in our practice, that's MAs, registered nurses, and licensed practical nurses. And it's sort of helped folks, again, sort of re-engage in their work, sort of start to push the envelope around what they're capable of. And I think it's been essential to our efforts to form a medical home.